the Interim Executive Director and Chief of Government Affairs for the National Association of County and City Health Officials, and I want to officially welcome you to this briefing. By the folks in the room, you can tell that this is a very important topic, one that we need to spend some more time and attention on, and we're just grateful that you could join us this afternoon. So NACCHO represents the almost 3,000 local health departments around the country, both city and county. And the name of our briefing, as you can see behind me, is Tackling the Opioid Epidemic and its Hidden Casualties, Local Health Departments on the Front Lines. So first of all, I wanted to let everyone know that we are live streaming, perhaps. You might be having some technical difficulties over there, but we're good, on NACCHO's YouTube channel. And a recording will be available afterwards. In addition, you can join the conversation on Twitter, and the hashtag should be behind me, not only the hashtag for the briefing, but also the Twitter handles for the three organizations. All right, so I just want to thank Congresswoman Lujan Grisham for getting us the room today. She is, and I want to also, I should start by thanking our co-sponsors, the National Association of Counties and the U.S. Conference of Mayors. We could not do what we do if we did not have such great partners. We do many things together, and we're pleased that they could be here today. All right, so Congressman Lujan Grisham. She is the esteemed chair of the Congressional Hispanic Caucus. She could sponsor this for us today, and I just want to do opioids. And her bill really is trying to get aim for this by putting opioid producers. So, and this is her Twitter handle as well. So we have an esteemed panel today. We have the Honorable Phyllis Randall, who is the chair of the Board of Supervisors from Loudoun County, Virginia. We have Dr. Michael Cable, Huntington Health Department in West Virginia. Lidia Mahalik, who is the mayor of Findlay, Ohio. So I'm going to talk a little bit about the state of play, where we are today with the opioid epidemic. And I just want to say that, you know, we're so pleased to have locally elected officials who are engaged in this issue and are here to talk to us about it today. It's the local communities that are addressing this epidemic. We're the boots on the ground, and we all need to work together to find the solutions to get us out of the place that we find ourselves in. It includes preventing opioid abuse. It includes addressing neonatal abstinence syndrome. It includes addressing the spread of infectious diseases such as HIV, hepatitis B, and hepatitis C, and addressing the effects of this epidemic on our workforce. So, since 1999, the number of opioid deaths involving overdose deaths involving opioids, including prescription opioids and heroin, has quadrupled, as you all well know. The illicit manufactured fentanyl, is very, very potent, more potent than morphine, and is the main driver of the recent increases in synthetic opioid deaths. Here are some more statistics, and as you can see behind me, here they are. So we've seen quite an uptick in deaths. The administration in the most recent weeks has also called a light to this issue, and number one, by declaring a public health emergency at the Department of Health and Human Services, and also the president had a commission that reported out most recently, headed up by New Jersey Governor Christie, and that also included a variety of recommendations for Congress, for the administration, for all of us to address this epidemic. And I guess the underlying message of both the Public Health Emergency Declaration and the Christie Commission report is that this is a multi-pronged epidemic that is going to take a multifaceted approach. It's going to also require more resources than we have put on the table to date. So how is the opioid epidemic affecting our workforce? We have seen a significant impact, and The Secretary of Labor most recently said that men ages 25 to 54 that are not in the workforce, 44% had taken a painkiller, both prescription, either prescription or non-prescription, the day before. That's astoundingly large. We also had the chairman of the Education and Workforce Committee in a hearing last week state that there's been a 25% drop in women in the workforce due to prescription opioids and a 20% drop in men in the workforce. We also have seen, there we go. Missing my slide, sorry. There it is, the infectious disease slide. Sorry, a little bit out of order. So in terms of infectious diseases, we saw in Scott County, Indiana, there was an outbreak and 223 people were diagnosed with HIV. And I think what we want to emphasize today is that we've got to, while we're addressing the opioid epidemic, we also have to address the infectious diseases. We're seeing an uptick in hepatitis C, and we unfortunately do not have all the resources that we need to address hepatitis B and C outbreaks. And so if we do nothing, the cost of caring for all of these folks is going to reach hundreds of millions of dollars over the lifespan of these individuals. And I think the health departments are in the right place in our communities to address infectious disease outbreaks, but we just sort of need to have the resources to be able to do that. Okay, so I just wanted to give you we just did a survey at NACCHO, which is called the Forces of Change, and we asked our members about partnerships in addressing the opioid abuse epidemic. And as you can see from the slide behind me, that we have seen a bunch of our health departments are partnering with their communities. Again, they cannot do this alone. They need to be working with their police departments, with their medical communities, with a whole host of partners out to be able to address this. So 1/3 of our departments have led or convened these partnerships, and the larger health departments are more likely to be engaged than the smaller ones. That's not to say that this is just a small or large health department issue. Obviously, this is an issue that affects all of our communities around the country. I would also point out, this is a slide from our Forces of Change survey as well, that just sort of shows you, since the recession of 2008, that local health departments have really struggled in terms of budget cuts over time, and that impacts their ability to address the opioid epidemic. In addition, we've seen a retraction in our workforce capacity over time. We've continued to lose jobs, and I think even if we were to see an uptick in funding, it would probably take us at least a decade to get back to the levels of the workforce in the health departments that we have had in the past. So with that, I want to introduce our first panelist. Our first panelist is the chair of the Board of Supervisors for Loudoun County, the Honorable Virginia Phyllis Randall. She was elected chair of the Board of Supervisors in November of 2015. She represents the county on the Board of Supervisors of the Metropolitan Washington Council of Governments, the Northern Virginia Regional Commission, the Dulles Area Transportation Association, the Northern Virginia Transportation Authority, and the Route 28 Transportation Improvement District Commission, and the Loudoun County Disability Services Board. Loudoun County has had 79 reported opioid deaths from 2013 to 2015. I'm going to bring the Honorable Phyllis Randall to the stage, but I want to let you know that we're going to have all three speakers speak, and then we'll do Q&A. So, thank you.
Thank you. Thank you for having me here today. You should know, just for knowledge from now on, when you tell your mother you're going to speak on Capitol Hill, she's going to call everybody from True Light Baptist Church. So they can come watch you. And every person she's ever known knows that I'm here today. So thank you for having me. Seriously, I want to thank you for the opportunity to speak today. It's an honor to speak in this room, and I want to thank NACHO, and I want to thank the Congressman Grisham for convening this meeting for such an important issue. As they said, I'm Phyllis Randall. I'm Chair-at-Large of the Loudoun County Board of Supervisors in Loudoun County, Virginia. I also happen to be Chair of Virginia State Board of Corrections, and by profession, I'm a mental health therapist. And I've worked in the field of substance abuse for over 20 years, but I worked in the prison system. So I'm a mental health therapist who actually works in the jails. This has been my life's work. I come from a family where there's a lot of addiction, and so I really understand the state of addiction in this, and the arena. So before I speak about my county's response to the opioid epidemic, I would be remiss if I just didn't take a minute to discuss the fact that we really should have to stop discussing individual substances when those individual substances come up. It's so important that we do not lose the opportunity to talk about the clinical issue of substance dependence and not just the substance that we're facing today. 25 years ago, we were talking about cocaine in the freebase form, also called crack cocaine, that completely ravaged the urban environment and the urban communities, and we didn't talk about that almost at all. 15 years ago, we were talking about PCP in liquid form, often called water, and not 8 years ago, we were talking about methamphetamine, and now we're talking about opioids. And I can guarantee you, about 5 years from now, if not a little bit more, we're going to be talking about designer drugs like salt and bath salts and that type of thing. At some point, we have to stop talking about each individual substance and talk about the disease of substance dependence, the clinical issue, if we're actually going to get a handle on those things. So I actually wanted to be sure to say that, and also to say, as we talk about the clinical condition that is substance dependence, it's going to require more funding, and I'll get to that in a little bit. Turning now to Loudoun County, when you came in, you saw this handout sitting outside. Let me just give you a little bit about my county. Loudoun County is a county of about 385,000 people. We are just about 40 minutes from here. We actually have the highest median income in the country. So we are a very, very affluent county. We have a very low unemployment rate. Unemployment rate is just 3.1%. We are highly educated, we are highly motivated, and we are highly accomplished. Having said all that, we have the same opioid crisis as everywhere else in the country. Between June and October of this year, 109 people visited the ER, and that's just people who made it to the ER, and they were there for accidental overdoses. We had 34 heroin overdoses and 20 overdoses for other opioid substances. The victims in Loudoun County are usually under 40 years old. They're usually Caucasian. They are often, if not always, college educated and definitely high school educated. In Loudoun County and in the state of Virginia, 3% of total ER visits have been because of an opioid addiction. The reasons opioids have become such a prevailing problem in Loudoun County and across the country are numerous, and some of the other panelists will discuss those reasons. And I'll be happy to take questions about those reasons after I finish. However, I wanted to spend most of my time talking about how we are addressing this issue in Loudoun County. First, we have armed our first responders with nasal Narcan. Narcan currently is only the FDA-approved form of naloxone for the treatment of opioid addiction. Narcan, I should say, is an opioid antagonist. In other words, it's not really for the treatment of opioids. It is used when somebody is in an opioid overdose, and when administered at the right time, will reverse the effects of the overdose. To date, our first responders have used nasal Narcan 56 times and saved 15 lives when they administer it at the right time. So the first thing we did was educate our first responders and then equip them with nasal Narcan. I should say the sheriff in our county is very involved in this process, very aware of the opioid addiction, and has been a partner to try to help with this. He actually was one of the people that led the charge in getting this done. Second, our Department of Mental Health and Substance Abuse and Developmental Services have partnered with the State Health Department to train individuals, so to train regular citizens on how to identify the signs and symptoms of overdose. This training can be offered to family members, but you have to receive the training in order to also receive nasal Narcan. It may seem a little strange that we would give Narcan to family members and to just normal citizens. Like, why would we do that? If you want to fight this drug, you don't give family members those drugs. But the truth is, remember, again, Narcan is not for treatment. It is just for, it's a life-saving measure. And so we realize that there are going to be people who are going to use opioids and use them in their house and in different places, and versus telling a parent what they should do afterwards, we at least give them the opportunity to help save their loved one at the moment. But it's not meant to be treatment, it's just meant to keep a person alive long enough to receive treatment. Third, I think we've done the most important thing in Loudoun County, which we have engaged in the conversation. I call it courageous community conversation about not just opioid use, but substance abuse in general. And the reason this was so important to me as a mental health substance abuse therapist is because I know one thing. Until we remove the stigma of substance use in mental health, we are going to keep burying people. People are not going to come forward to get help or assistance or admit that they use this drug until we actually begin a conversation about it. Mental health is health. And until we make that normal and normalize it, we're going to keep burying people. So who did we bring together? Well, Loudoun County brought First County Government, Public Safety, the nonprofit and faith communities, and the nonprofit and faith communities actually should be called on more. They can't do this, but they can certainly help with this issue. And they have been some of the people that have been trained to have the nasal Narcan in their possession. Public safety officers, private industry, health providers, family, and clients have come together for training sessions and community forums where we talk about the opioid epidemic and substance abuse overall. I think it's really important, one thing I said, which is we actually have people who are substance abusers as part of this conversation. I think we forget that sometimes. In our zeal to want to help people who are using, we forget to include them in the conversation and ask them, how did this come to be? Why did you start using? Many did, and somebody will talk about this later, because they started using prescription drugs, but not everyone started using opioids medication because of prescription drugs. And so there are many reasons people start to use. So for them to have that conversation, to have the conversation about what are you most afraid of if the drugs are taken away from you, is a conversation to have. You are surprised with what they say, to ask after you get over being dope sick, which is what the term is for the detox. After you get over being dope sick, which is such a terrible experience to go through, you go back to the drug again. Why does that happen? Because we're often told that people won't, it's just about being dope sick, that they don't want to be sick, but they still go back. Why does that happen? So some of these questions can only be answered by people who are using the drug. And so everyone should come together, but please don't forget to bring in the conversation the people that actually use the drugs. Finally, I want to speak to President Trump's declaration of opioids as a health emergency. The president is correct. Substance dependence is a health crisis, and it's one that we cannot arrest our way out of, and we definitely cannot incarcerate our way out of. I work in a jail. I've known many people to come to the jail, to not choose to receive services in the jail, to leave the jail, to use again. Their tolerance has gone down and they die. You cannot incarcerate your way out of any disease, and this one is no different than any other. However, declaring a health emergency without offering any additional resources is akin to saying, I want to get a job, but I don't send in a resume and I don't go for interviews. It's fairly unlikely you're going to get a job. We actually have to put money behind this. If we as a nation are seriously going to address this crisis that is devastating tens of thousands of families across America, we need a sustainable funding source, and we need a strategy that is malleable enough to respond to individual communities, yet broad and inclusive enough to be applicable to any and every community. Almost 60,000 people died last year in America from opioid abuse. So the idea that we can tell people just say no is not enough anymore. You just say no if you've never touched the drug, if you've never touched drugs. But once you are an addict, just saying no is not a viable solution anymore. And so to put that forward as an option, once somebody starts using, is not an option. So we need resources, we need funding, and we need partnership. So I thank you for allowing me to speak. After the other two speakers, I would be happy to take questions, and I appreciate being here. Thank you so much.
Great. All right, our next speaker is the Health Director for Cable Huntington County Health Department in West Virginia, Dr. Michael Kilkenny. Dr. Kilkenny's town of Huntington, West Virginia was the focus of the recently released Netflix documentary Heroin. Dr. Kilkenny has implemented the first syringe service program in West Virginia, and he's here to share his story as well as some of the outcomes of this program. Dr. Kilkenny, please join us.
Thanks very much. I really appreciate coming here. Let's see if I can get this closer. My voice does not carry even to a microphone. I do want to thank Congress for the work that they have already done tackling the opioid epidemic. The comprehensive, I have to read it, we call it CARA at home, but the Comprehensive Addiction and Recovery Act and the 21st Century Cures Act are both very strong legislative pieces to battle this epidemic, and we are very thankful for the work that's being done at the Capitol on behalf of the people who suffer from this disease. And substance use disorder is a disease. We treat it like a moral failing, but it is a disease. It has treatment. People get better from it. We need to treat it like it's a disease. I'll step down from my soapbox for just 1 minute. These legislative acts have focused primarily on prescription drug use, and prescription drug use is still a big problem, as you could see from the slides that were already shown. But prescription drug use is just the start of the cycle for the people that we are working with in Cabell County, West Virginia. Cabell County has 100,000 people. The city of Huntington has just under 50,000 people. And in 2015, overdose death was the third leading cause of death in the city of Huntington. You can't ignore that. As a health officer, you need to get excited about battling that because that's reversible. And today, I don't want to focus on how bad it is. We can play one-upsmanship from one state to the other. You know, we're number one in hepatitis B, and Kentucky's number one in hepatitis C. And we're not really trying to win that. But we're number one in overdose death. We're number one in neonatal abstinence syndrome. And we need to change that in West Virginia. In West Virginia, we're dealing with primarily injection drug use, and we're dealing primarily with fentanyl and the fentanyl derivatives. Those would be like carfentanil. We still have a prescription drug problem in some of our counties, but in Cabell County, if I only had the deaths from prescription drugs, I would not be here talking to you today. But I do want to, again, focus on some of the things that work. the last speaker mentioned naloxone. Naloxone is an antidote. It is a preventative for death from substance use disorder. It is too bad that we apply that preventative only seconds before the person dies. We need to move that prevention way upstream, but that prevention does help. I do have a slide, and that's it. I'm going to get in trouble. This is preliminary data. I do have it confirmed from our state Division of Vital Statistics. They told me that I could share it on a need-to-know basis. I think you all need to know, because I think that we've heard too much bad. We haven't heard enough good. We don't know if any of the products or any other projects that we've had are working. Let me show you. When your EMS is well equipped to deal with overdose, EMS saved this percentage of people in Huntington in 2015. In 2016, they saved this many people. This is number of people. The blue is dead people. These people never get the chance to recover, but these people do. We started a community naloxone program, giving naloxone to the families and the people at the highest risk. And we saved this many additional lives in 2016. In 2017, to date, this many people have died, but more than half have been saved by these programs, and this is a huge block of saved lives from the community naloxone program, in addition to the first responders. The first responders are busting their tails to respond. Our EMS will respond to 2,000 overdose calls this year. The next thing I want to talk about is syringe exchange. I did not start the first syringe exchange in West Virginia. Syringe exchange has traditionally been something that drug users did for themselves to help themselves avoid disease because nobody else would help them. The Cabell Huntington Health Department started the first sanctioned syringe service program in the state of West Virginia. And placing that in a health department, besides giving the clients, the people who actually suffer from the disease, somebody that they trust to talk to, also gives us the opportunity to capture data in epidemiologically sound terms. And I have 2017 data in my county because it's my job to have 2017 data in my county. So health departments are very well situated to provide these services. In 2015, when we started our program, the first month that people came in, they had no access to sterile syringes before. 28% of them admitted sharing syringes. Last year, the people who had never been to our program before were sharing at a rate of only 16%. So even people that we had not touched were benefiting from the program that we had placed in our county. And the people who came to our program, even once, were sharing syringes at 4%. Now, hepatitis C, hepatitis B, and HIV are infectious diseases that are spread by sharing needles. Syringe service programs work. They reduce syringe sharing. I can't yet show data to say that I've reduced the disease, but I do know now how many cases of hepatitis C that I have to treat. And in Cabell County, we have laid our hands on enough hepatitis C to cost $100 million in the drug cost alone at the current West Virginia Medicaid contract price for that drug. The EMS that is responding to overdose is paying sometimes as much as $50 a dose for a decades-old generic drug. Prices are through the roof for these drugs. So there are a couple of things that we need, and we have a legislative body to ask for this help. We need some additional funding to support the purchase of these products, and we need some price negotiation power to lower these prices. If we don't, we are stuck with a long-term epidemic. Current policies will maintain that epidemic. We need to stop that. So those are a couple of things that we would like our legislators to help us with. Just in closing, I want to say that there are people in this room who have family members. There are people in this room themselves. There are people in this room with friends who have substance use disorder. And they need help. Every one of those people is served by a local health department. The local health departments are authorized, boots on the ground, an army to fight this disease. And the federal government can use us. We just want you to call on us, drive some resources down to us, and make us strong enough to really affect this public health emergency. Thank you.
Thank you. All right, so our third panelist today is the mayor of Findlay, Ohio, Lidia Mahalik. She was elected as the first female mayor of Findlay in 2011 and named to the advisory board of the U.S. Conference of Mayors in 2017. Mayor Mahalik is also the chair for Children, Health and Human Services Standing Committee at the U.S. Conference of Mayors, and she's here today to talk about the epidemic in her city. Please come up, Honorable Lidia Mahalik.
Thank you so much. Well, good afternoon. Nothing like asking a mayor to back cleanup. I'm very excited and grateful to have the opportunity to speak with you today about something that is impacting us regardless of city size or political affiliation. It's an important topic to discuss. I'm here to talk on behalf of my city in Findlay, Ohio, which is in northwest Ohio, situated about 45 minutes south of the city of Toledo in northwest Ohio. But I'm also here on behalf of the United States Conference of Mayors, where I serve as the chair of the Children, Health and Human Services Standing Committee. My committee oversees all the policy positions related to substance use disorders, including opioid addiction. And just by way of background, the U.S. Conference of Mayors is an 85-year-old nonpartisan national organization of the nation's mayors. We represent cities with populations over 30,000, but in actual practical work, we feel we represent all cities in the United States. In addition to my committee's work, we also have the Substance Abuse Prevention and Recovery Task Force, led by my fellow Ohioan Dayton Mayor Nan Whaley and Boston Mayor Marty Walsh. On behalf of them and their great work, and our Executive Director Tom Cochran, and our President Mayor Mitch Landrieu, I bring you greetings. We've had some great comments that have been offered today, and hopefully I have a few minutes here briefly to touch on this conversation as presented. The U.S. Conference of Mayors work to advocate for drug prevention, drug treatment availability, and resources at the local level spans several decades. The effect of this epidemic can be seen in every part of our society, from our healthcare system to workplaces to homes and local communities. The public health challenge that our nation faces today, it's our collective duty to work towards a healthier and stronger America, and mayors are already driving this work forward in their communities. We've heard several examples of how that's being done in cities and counties across this country. And there are things from needle exchanges to naloxone availability to educating the public about what an overdose actually looks like so you can respond to it, similarly to the way you would respond to someone who's suffering a heart attack or is in need of CPR. These are important advances in the way that we address this critical public health crisis. And as mayors in the state of Ohio, a bipartisan coalition of mayors of Ohio's 30 largest cities came together just last year. And we evaluated all of the different things that cities from across Ohio were doing to help combat this particular epidemic. And we're doing a lot of the same things that we talked about today. We're looking at ways to potentially provide mutual aid between jurisdictions in cities across the state. And we came together and evaluated what was out there, and not just in governmental programs, but also in our nonprofit partners as well. And what we found is that there's a tremendous amount of things being done, a tremendous amount of innovative things being done. And so what we did is we came together and we put together a small report that talked about treating the opioid epidemic as a state. But the reason why we did that is because we realized that we were still missing some things. And we knew that there were gaps in the service that we were providing people across our state. And as folks who are on the ground, boots on the ground, as has been discussed, we also realized that we can't fight this alone. We need partners at the state level and the federal level. And so we came to Governor Kasich with a list of 7 recommendations that included things about policy changes that need to be made with the Medicaid expansion, but also just opening up our Emergency Operations Center. And what was funny is that while the mayors were suggesting that we open up our Emergency Operations Center at the state level to have a better coordinated response to this issue, we found that apparently the Emergency Operations Center was already open, but that wasn't being communicated to the cities across the state. And so there were several things that we came and had a great conversation with Governor Kasich about in order to help make things better. Because as leaders in our communities, we've sought to understand that there's definitely more we can do and what exactly that is. And as I said, many of us have equipped our first responders with Narcan, and we've helped facilitate intergovernmental working groups to share information and accelerate our response strategies. We've also worked to understand what efforts our peer communities are doing to learn more from one another and share best practices. However, from our perspective on the front lines, it's become clear that a more coordinated and comprehensive strategy between all levels of government is needed. And this is not to suggest that there haven't been some important policies enacted, specifically in the state of Ohio. The expansion of Medicaid has provided critical medication-assisted treatment and access to outpatient and residential treatment services. The expansion of ORS, which is our prescription record group, and also new limits on opioid prescribing, Project Dawn, which is deaths avoided with naloxone, and other various grants included in the most recent state budget are all important measures that are definitely having an impact. And we want to continue to build on the work that's been done so far, because what we're seeing is not a decrease in overdose deaths. We're not seeing a decrease in the amount of people who are addicted to prescription drugs or a decrease in the amount of people who are addicted to opioids. In fact, it continues to go up. And so this is an opportunity for us to come together, to find additional ways to strengthen our collective response to this crisis. And that doesn't stop at the State House. We need partners in Washington. We need partners across this country to help us evaluate what works, to have innovative approaches, but we all have to know what we're doing together. The left hand and the right hand need to come together, and we all need to be on the same page. And when we do that, then we can have a better ability to fight this crisis and hopefully work to combat and solve this public health issue that we're in at this point in time. Thank you very much.
Okay, one last slide, and then I will get our speakers up here, and you get to ask them lots of great questions. I just wanted to remind folks of some of, these are not obviously all of the federal funding streams, but these are some of the federal funding streams that we have to address this epidemic. I would say there are obviously streams at DOJ and other parts of the federal government. And in addition to CDC's prescription drug abuse prevention and their illicit opioid use risk factors, they also, we talked about sort of the infectious diseases increasing, and Dr. Kilkenny talked about hepatitis C and hepatitis B, and I should probably put up here that the Division of Viral Hepatitis at CDC receives a whopping $34 million. That's $90,000 per state. That really is not enough to equip the state health departments, much less the local health departments, to do a whole heck of a lot in addressing the hepatitis epidemic that we have in this country. And we have curative therapy for hepatitis C. So again, obviously the CDC money is for prevention and we do treatment elsewhere, but it's important to note that we do have funding streams that we could use up further to address this. And if we do nothing, if we don't, with our public health emergency declaration, and if we don't provide additional funding, we will continue to see the ticker go up and up and up in terms of our healthcare costs. $183 billion is needed to cover the health costs associated with the opioid epidemic, and it's just going to get larger. And we need a greater investment by the administration and by Congress for an epidemic that kills 91 Americans a day. So we have to work together, both at the local, the state, and the federal level, as was previously said, across our many agencies and partners and community-based organizations, faith-based organizations, to really get a handle on this. So now, this is the fun part. We are going to bring up our three speakers, and you can ask them all sorts of questions. And so we don't want you to be shy, because you have three fantastic folks out in your communities. Does anyone want to go first? Or, okay. Maybe I'll warm them up a little bit before you guys come up with your questions. Oh, I see one. Okay, why don't you go first?
Sure. Hi, so my name is Mahalik. I think, as with a lot of other things, this is kind of coming down to, I think all three of you would agree, the need for more federal resources, namely funding. Do you have any idea of the specifics of that, or where it would come from, and kind of how do you see those funds being allocated?
Okay, I'll try it. Well, okay, I'm not sure I need that. Can you guys hear me?
Yep.
Yeah. Okay. So something the doctor said was really important, which is this is not a. We sometimes look at people who substance use and the disease of substance disorder as a moral flaw, and it's not. And just as we have found the funds to deal with all types of other diseases, we have to find the funds to deal with this. When I think about what we did as a country not many years ago with nicotine, and the fact that we went on a very large education, prevention campaign for nicotine, and there was federal funds put into that. And so when human health dollars, Medicaid dollars need to be brought to bear for this cause. And I think we should also remember that we're paying the price anyway, because we often incarcerate people who use substances, and it costs a whole lot more to incarcerate someone than it does to do preventative services. So it may be a time where we put money up front, and then we find later on that we can pull money out of some other systems because we've put money into prevention and education. How you allocate it, I think that's hard. I think you can't just say what's the population of this state and that's how much money they get, because we know that West Virginia, Ohio have been hit harder than other states. So I don't know how the allocation will work, but I know that we we don't really have an option anymore about whether we find the funds, because we're spending the money already.
I would just say that one of the ways that we could take money that's already been allocated and use it more effectively, we've already proven that syringe service programs are effective in reducing sharing of syringes. They are a CDC recommended intervention for this problem, but the spending of federal dollars on syringes is prohibitive. Lift the prohibition. Without allocating any more money, we'll get a greater effect.
From my perspective, I feel like, the president's most recent task force on this opioid epidemic had some really good suggestions in it. Suggestions around prevention and education. Suggestions on how we talk as a nation about, let's bring back the say no to drugs thing again. There needs to be resources placed behind some of those suggestions. And I think that there's some quality ones in there. But suggestions are just suggestions until we actually get to implementation. And so I think from Congress's perspective, they could take a good hard look at what is involved in that particular report and figure out what priorities they want to get behind so that our public health groups from across this country can start to get to work on hopefully at least holding the numbers to where they're at. I mean, we're not even there yet. So that we have to do something, and I think that's a really good place for Congress to start.
Okay, other questions? Okay.
Yeah. Dr. Copan, what effect is this having on your workforce as far as dealing with overdoses constantly? And how does your staff dealing with death on a daily basis, dealing with drug overdose on a daily basis? And I guess all three of you can answer that question. But what are you seeing from the staff level?
It's an excellent question. Do I need to stand?
You're okay. You're pretty tall.
You want we aren't feeling the brunt of the death and destruction like the first responders are. The first responders are used to saving people. They are not used to going into houses and finding dead young adults with their children. And it's taking a huge toll. We are implementing programs of support for the first responders. I have a colleague in Charleston, 50 miles away, a city the same size as ours. Dr. Brumage is an expert in trauma-based treatment and mindfulness, and he's leading the charge in the state regarding that, as well as the effect on the children of all of these people who have lost their lives. To lose a parent is an extreme stressor for a child and puts them at risk of following the footsteps. Mass incarceration has a very bad effect on the children of the people who have been put in jail, and it causes a generational following. So with the opioid problem, we've got to not only deal with the people, the adults who are working here, but one of the real hidden victims are the children who are suffering this trauma, being put at risk to have another generation that we have to do the same thing with, unless we can intervene with that generation to tell them that this is not what's wrong with you, this is what's happened to you, and you can be all right.
Let me paint this picture for you. So you're absolutely right, Doctor. Our first responders are dealing with this in ways that I don't think they ever thought that they would when they took the oath. 27-year-old male is reported to be not breathing in the basement of mom and dad's home. Firefighters respond on scene. Mother is hysterical. She ushers the firefighters downstairs to the basement where the son is not breathing. Father is up at the top of the basement stairs with 2 toddlers who are watching their father not breathing. It's a completely traumatic experience. And they're working as hard as they can to try and revive this particular individual. And sometimes it doesn't take just one shot of naloxone. Sometimes it's multiple injections of naloxone. And then after, they revive that individual and it goes on, and he goes to the hospital for care. The next day, the teachers in our school system who are now trained in trauma-informed care are having to deal with the children of the victim, of the person who overdosed. You're right, the children are the hidden victims in all of this. Last year, we had more than 100 children removed from homes where the parents, either one or both, were involved in opioid abuse. This is a real issue, and it's tough for the first responders who have themselves young children and have to go home at the end of the day. So I think it's definitely taking its toll, but the families are being ripped apart from this horrible issue.
My name is Emmett from Senator Whitehouse's office. I just wanted to thank you for coming and speaking to this. I liked how you spoke about the stigma. I think that's a very important topic. In what ways do we eliminate stigma behind getting people to seek treatment? And kind of follow-up question, why is it that is so common that the people that are dying, most people that are using the most in terms of opioids, why is it always middle-aged, or mostly like middle-aged white men, and what can we do to, I don't know, occupy these people and reduce their, wanting to turn to opioids in terms of,
Okay, I'll speak on the stigma first. I think we have to start talking about this disease like we talk about other disease. I wish we said remission instead of, when we talk about how long somebody's in recovery, we say recovery instead of remission. If we start using medical terms for the medical problem, maybe we would see it differently. I also think we just have to start having a conversation. When we think about 1 in 5 people will use substances in their life, that's not an unusual number. That's a very high number. And the problem is we always talk about it in a very shaming way. Like if you just had more self-control. I worked in the jail for many years. I can tell you, people that I work with have lots of initiative. It takes initiative to be an addict. Being an addict is hard work, right? To get up every morning and figure out where you're gonna get your drug from, while you're dope sick, that is hard work. So it's not that they don't have willpower, it's they have a disease. The second question is a little harder, and the truth is not a very popular answer. There were quite a few studies done, and it was asked, why is this particular drug hitting white America stronger than it hit black America? And one of the answers was because doctors often, not realizing it, believe that black Americans can handle pain better. Right? So because black Americans can handle, or minority Americans handle pain, they don't get the prescription drugs that are handed out to white America. We can't handle pain better, but that's the belief. Also, America's 5% of the population. We use about 85% of opioids. Americans cannot sit in pain for 5 minutes. It's just not who we are. So, pain management from other places where you give somebody a cup of Tylenol, put a pack of ice on that, and go kind of, you're good. It's not who we are, right? We are not people who are comfortable sitting in discomfort at all. And all those things, all those social cues have led us to where we are right now in this crisis. It is why you see the crisis larger in some areas than other areas. And also, of course, any kid can go to the grandmother's house, grandfather's house, open the medicine cabinet, and there is their drug of choice sitting in the medicine cabinet. So there's a lot of issues that actually happen. I will tell you one thing, working in the jail for many years, I learned something about opioids. The one thing that really is different from every other drug, because I worked with substance abuse inmates for years. and they talk about a bad batch of drugs as garbage. So they say, like, if you get PCP and you get, this is their talk, if you get PCP and you get stuck, that's what you got, the garbage drug, right? So no one else would go to that dealer and get that PCP, because that PCP is garbage. With opioids is different. If you get garbage and you die, every opioid addict within a 10-mile radius is trying to find that dealer with that drug, because opioid addicts are trying to get as close to death as possible without dying. So that's why it has a much higher rate. When they know somebody died, that's where they're all going to go to get it. And that is one of the things that's different and takes up that death rate.
I was surprised to only hear one of you speak about the reduction of, so you talked about the pharmaceutical aspect of it. I was surprised to only hear the mayor discuss giving patients less opioids, because that eventually will lead to addiction. You have a surgery, you're given too many pills, and you end up getting addicted to those. So like, I was just like, that just seems like such a reasonable solution.
It does, and again, that's about us not being able to live in pain. When someone has a root canal, they don't need 11 days of opioids for a root canal. They take maybe a day, and then you're gonna be all right, right? Right after a day. So yeah.
I think really, and I'll be quick because I know we're running out of time, but I think, you know, from the perspective of the education piece, 75% of the people who are addicted to heroin are addicted to heroin because they started in a prescription pain pill. And we did a really good job of shutting down the pill mills, but doctors and pharmaceutical companies got it wrong on the prescription pain medication. And so it is the more education we can bring to people. I think young people in particular, young people who get sports injuries, it is very easy for a doctor to say, you know, here's a prescription for 60 days. Call me if you need a refill. And I think our doctors are getting smarter about this. In Ohio, we do have this new ORS database, which has definitely decreased the amount of prescription opioids that have been prescribed, but we're still seeing an increase in deaths. We're still seeing an increase in the people who are addicted. So I think that's just one prong of the approach to try and fight it. But the more we talk about how you don't need, 11 days worth of pain medication for a root canal, when you get your wisdom teeth pulled, a couple days is good. A month is not okay. And I think parents who are kind of hip to this right now, their kids are, and I hate to say suffering, but in a way they are, because parents are saying, no, my kid can just take the Advil.
It's better than leading to death, right?
That's right. Because if someone told you that you had a 1 in 4 chance of turning into a zombie every time you took a pain pill, you probably wouldn't do it. And I don't think we're communicating that enough, but we're getting there. It just takes time. We didn't get here overnight, and it's going to take us time to solve it.
All right, any last question for our speakers?
Yes. There's one on the live feed.
Oh, there's one on the live feed. Okay, let's go.
Not sure what this person's name is, but they asked, they say it sounds like a lot of health departments online are looking for a solution, like trauma-informed care has to be a big part of this for families and other concerned individuals. Is there going to be a discussion on harm reduction in addressing this issue?
I think this discussion about trauma-informed care is such a good one. We actually don't realize how traumatizing it is what the mayor just described to a family. So having those discussions and having trauma-informed professionals working with you is incredibly important. So I would associate myself with the mayor's comments. Harm reduction is the needle program that the doctor talked about. It is not something you think about first, like hand out more needles, but it actually works. Some of the therapy programs that worked in local community services boards are almost sound like bribing people. You know, I walked into my supervisor's office one time, and my clinical supervisor, and she had a whole wall of candy. And I reached for a Snickers bar, and she said, "Don't take that Snickers bar." I said, "Why can't I? You have 300 Snickers bars here. Why can't I have one?" And it's because they were having, for the opioid clients, if you were staying clean for a certain amount of time, they gave you a Snicker. And I thought, that can't work. Like, that's never going to work. I mean, once you get past being dope sick, not while you're dope sick, but once you get past. And actually, some of the studies show that when people are clean, they want a reward for being clean. And it doesn't sound logical to give adults a candy bar for not ruining their lives, but you know what? It actually worked to give adults a candy bar, and what this program did was the prizes or the rewards got increasingly greater until they ended up with a Target gift card of $100. And it really worked, and I was very surprised that worked. So there are a lot of harm reduction programs, things that we don't think about, things that we might say, come on, just have some strength and you won't do it, that actually do work. I think we have to think outside the box on some of these issues. We have to try new things, and we have to continue to talk about it, and talk to the children of addicts, no matter what the substance is they might be using. Otherwise, the next generation will live what the last generation just saw, what the last generation just did. Thank you.
I can just tack on about harm reduction. Harm reduction is a lot more than the needle. Sometimes the needle is just a carrot to get them in, and then we offer them education, we offer them immunizations. If they haven't had their hepatitis B immunization, we can immunize them, we can test them for HIV, we can talk to them about how to avoid, and these are not stupid people. These are everybody. They are us. And they're hungry for knowledge, as well as just a caring word from a health professional. When you are used to being talked to like a dog, just to hear somebody say, "Boy, I hate that you're having this problem. How can I help you?" They don't even know what to do with "how can I help you." They are already recoiling. They're already flinching. What are you going to say to me? I'm going to say, be safe. And harm reduction has to do with making that person's life as productive as it can be when they're suffering from this disease at the level that they are. And they suffer from the disease at different levels. There are some people who want that, they're chasing that dragon. They want to be as close to death as they possibly can. But most of the clients that I talk to don't want that. They think that's stupid. Their brains are not hijacked by this drug to the point that they lose all of their ability to make decisions. They will, in fact, go seek out that powerful drug, but sometimes it's because the more powerful drug I can use less, and it will be that many more days before I have to cheat, lie, and steal to get more, and I don't like to cheat, lie, and steal. So harm reduction is much broader than just the needles. The needles are fantastic disease preventative. They are not enabling for the drug use. To be enabling, you must give them something that lets them do something that they wouldn't be able to do without your help. Prevent the disease is what we're enabling. They were going to find a dirty, rusty needle, and if they had to drive it in their arm with a hammer, they were going to use it. Let's give them a sterile one, and they won't get sick.
So needle exchanges are definitely the most widely known method of harm reduction. In some cities in Ohio, not all, in some cities in Ohio, they're offering fentanyl test strips to determine, how potent the drug is. And they do that in combination with the needle exchange, in combination with counseling for the addiction. But you're right, it's not the only thing. It is kind of a means to get people to listen. It's important.
All right, well, I want everyone to thank our 3 fabulous speakers one more time. I also want to thank the National Association of Counties, the U.S. Conference of Mayors, and our own Ian Goldstein at NACCHO who put this briefing together.